Hello, this is John Neary, and I'm doing another one of these short talks on renal topics for students going through the renal rotation in the Royal Infirmary, and this is also uh, usable if you're doing second year renal lectures and your patient-based learning. So I'm going to approach this in looking at a number of things. First, we'll look at strategies to prevent progression of kidney disease, then how to prevent complications, and then how to treat the complications. So if we start off with strategies, one of the questions that I tend to ask students when they come to clinic is proteinuria a marker or a cause of kidney disease? So if you've got somebody with diabetic nephropathy with significant proteinuria, are we looking at proteinuria just as a marker, or is it more important? The next slide illustrates this in 4 stages. So the first stage is that we all excrete a certain amount of protein at the glomerular level, but is reabsorbed across the tubular cells and processed. However, if you're diabetic with heavy proteinuria, you'll overload the system, and the tubular cell will essentially die. Stage 3 is when you get macrophages and fibroblasts coming to clear away this dead cell, and they will leave back some scarring or some interstitial fibrosis. One of the markers of chronic progressive kidney disease is lots of interstitial fibrosis. Stage 4 here merely illustrates the fact that if you give somebody RAS inhibition by using an ACE inhibitor or an angiotensin receptor blocker as antihypertensive agents, you preferentially vasodilate the efferent arteriole here, and this drops the intraglomerular pressure. And you know from lots of studies that this retards progression of proteinuria kidney disease. The next part of how to prevent complications, and this really is about drugs. So in patients with decreased GFR, you need to be very careful about drug dosing. You'll need to reduce the dose of a lot of antibiotics and other medications. You should check the BNF. You also need to try and avoid some potential toxins. So you should avoid non-steroidals, avoid contrast, and avoid things like phosphodienamines in these patients, as these can all worsen renal function. I've looked upon the urinary complications and I've divided them into excretory and endocrine causes. So the first one in excretory is that of salt hypertension, as obviously the kidney can't excrete salt very well, so a lot of patients develop high blood pressure. So hypertension can be due to chronic kidney disease, but it can also cause chronic kidney disease. We do know from general medical patients that end-stage or that hypertension can cause left ventricular hypertrophy. It can increase your incidence of stroke, it can cause end organ damage affecting the eye and the kidney, etc. Normal blood pressure treatment goals in the population are less than 130/80, but in patients with diabetes or proteinuria, it should be a little bit lower, less than 125/75, and we should use RAS inhibition as discussed earlier. In the general person that come in, you'll first start with salt restriction in the diet and advise them to cut back on salt. Then you'll go into lifestyle modification, advise them to try and lose weight, to get down to an ideal BMI, stop smoking, increase exercise, decrease alcohol, etc. And if these things don't work, then we move on to various drugs. Second excretory problem is that of potassium. These patients with chronic kidney disease are unable to excrete potassium, and they can develop hyperkalemia, which is, as you know, is life-threatening. So it's important to monitor potassium. The typical foods which are high in potassium are things like the typical student diet, so bananas, orange juices or fruit juice of all types, coffee, chocolate, beer, crisps, basically anything that tastes nice. The last excretory problem is that of acidosis, as these patients with chronic renal failure can't excrete acid as well as patients with normal renal function, and a lot of the acid is derived from animal protein in food. We aim to keep the sodium bicarbonate level of greater than 22, so that often involves replacement of sodium bicarbonate. You just need to be a little bit careful with this because it can cause fluid overload in patients with chronic kidney disease and patients with heart failure. For some reason we skipped over the anemia slide, but I'll talk about it anyway. So anemia in patients with chronic kidney disease is common, and a lot of people say that the most common it's only due to EPO deficiency. So EPO or erythropoietin deficiency does occur in these patients. However, there's another number of other factors. So The anemia tends to be normochromic normocytic, so this is anemia of chronic disease, and these patients have decreased red cell survival due to the general inflammation that's going on within their system. They also may have iron deficiency, which may be absolute due to very low iron stores, or functional, where the iron stores are adequate but one can't access the iron. This tends to happen in patients with infection. And finally, they may have things like B12 and folate deficiency. So our slide here, we aim to replace EPO in these patients. Anybody with a hemoglobin of less than 10 and adequate iron stores, we give them recombinant EPO, and we have a target hemoglobin between 105 and 125. We don't push any higher than this because of complications. Importantly, if you have somebody who's on EPO and isn't responding, then you need to check the iron stores. Just make sure you haven't used all the iron very quickly. Check a CRP or a septic screen to make sure there's no infection there. Check B12 and folate to make sure you're not deficient in that. And then there's a few other things at the bottom of the page there, kind of associated with inflammation. We also need to look at. Renal osteodystrophy is the next endocrine thing, and this is renal osteodystrophy is an umbrella term, and it looks at a number of causes of bone disease in these patients. The high turnover bone disease and low turnover bone disease. And in the next slide, I'm going to illustrate this. So, patients with chronic kidney disease can't to perform an hydroxylation process to activate vitamin D. So they have low vitamin D levels, and they will absorb less calcium from the diet. This will lead to osteomalacia or rickets in children. In response to this low calcium, then the PTH level goes up, so secondary hyperparathyroidism, and this will increase calcium absorption from the gut, but also increases calcium and phosphate absorption from your own bones, so you can develop osteotis fibrosa, which is a form of bone resorption affecting the fingers and the skull, etc. The net effect is that you end up with a low normal calcium level, but your phosphate level goes up quite high. Because your kidneys aren't working, you can't get rid of this. I mentioned a few other things at the side there. So osteoporosis isn't necessarily a renal bone disease, but because of the fact that quite a lot of our patients are old and frail, they may have osteoporosis as well. ABD refers to a thing called adenine bone disease, as with some patients, when we give them back replacement vitamin D, they oversuppress PTH, so it's iatrogenic. And some patients who are exposed to aluminium develop aluminium laydown in the bones and can weaken the bones. So if patients have renal bone disease, we have four things to do. We phosphate restrict them by reducing the phosphate in diet, which is mainly meat and dairy. If their phosphate levels are still high, we put them on phosphate binders, which are tablets which bind phosphate within the gut. And these will be calcium containing or non-calcium containing. Secondly, we do is we give them vitamin D therapy, a form of vitamin D called alpha calcitol. We keep a close eye on their PTH levels, and they may still require parathyroidectomy because they may develop tertiary hyperparathyroidism. Hyperphosphatemia is not a benign process. It can cause vessel calcification, which will go on to cause systolic hypertension and left ventricular hypertrophy and diastolic hypertension, and increased myocardial ischemia, and it could also lead to a very nasty complication called calciphylaxis. We're coming towards the end now. There's a number of increased cardiovascular risk factors in end-stage renal disease. Here you can see the risk factors, general risk factors on the left-hand side, a few in the middle that are increased in chronic kidney disease, and a few on the right side which are unique. And finally, malnutrition is common in kidney disease. I mentioned lots of dietary restrictions earlier: sodium, potassium, phosphate. So these patients can have decreased protein intake. They can also have decreased appetite because they feel awful. And it's important that we keep a close eye on these. So we have very dedicated renal dietitians to advise patients. We do know that patients that are malnourished do worse on dialysis long term. So that's the end of the talk. There's a few references here that you can look at. Sorry that this has gone on a bit, but hopefully it will help with your studies. Okay, thank you. Bye.